let's talk about the management of colorectal cancers now. And if we talk about the management, the treatment modality is available to us as surgery. We have chemotherapy. There is radiotherapy. Radiotherapy is only for rectal cancers. So please remember this, radiotherapy is only for rectal cancers, and you can have immunotherapy as well. So remember this, radiotherapy is only for rectal cancers, and the final treatment modality can be immunotherapy. So let's talk about each of these modalities in detail. First, let's talk about surgery. But I'm going to talk about surgery for colorectal cancers, and I'll talk about colonic cancer separately, and I'll talk about rectal cancer separately because they both are quite different. And first I'll be talking about colonic cancer, and before I talk about the surgery, I want you to know some basics regarding the anatomy of the colon. I'm sure Dr. Ravi Raj has covered all this, but this is important to determine what kind of surgery we do. So a quick recapitulation. This is your terminal ileum. You have your cecum, ascending colon, hepatic flexure, transverse colon, splenic flexure, sigmoid colon, and finally you have your rectum. Okay. Now, you have a superior mesenteric artery. This one is the SMA, superior mesenteric artery. The red one is SMA, superior mesenteric artery. It gives off an ileocolic branch. This is an ileocolic branch. The appendicular artery is a branch of the ileocolic artery only. Then you have a right colic artery, which supplies the ascending colon. Then the superior mesenteric artery itself splits into the middle colic artery. And the middle colic artery has a right and a left branch. Fine. You also have an inferior mesenteric artery. The brown one is the inferior mesenteric artery. The inferior mesenteric artery gives off a left colic branch. It gives off a branch to the sigmoid. This is the branch to the sigmoid. And it gives off a superior rectal artery as well. Okay. So these are the various vessels which are supplying the colon. Now, one thing is very obvious. Just when you look at the diagram, you can make out that this area, that is the area of the splenic flexure, is the watershed junction. The splenic flexure, you can see, is not getting very good blood supply. So splenic flexure is one of the watershed areas. It is one of the watershed areas which is not getting good blood supply, and this is known as the Griffith point. This is known as the Griffith point. And if you remember the module on upper GI hemorrhage, I told you 2 points. I told you that the most sensitive mucosa in the GIT to hypovolemia was the gastric mucosa, but the most common site for ischemic colitis, where ischemia can occur in the colon, that is the splenic flexure or the Griffith point, because it is a watershed region. This will also have a bearing regarding the surgery which we do. I'll tell you when I talk about the surgeries. The other watershed region is the rectosigmoid junction. The rectosigmoid junction is the second watershed junction, and this is known as the Sudex point. This is the Sudex point, which is the watershed junction. Another thing which you should know is that all the lymphatics lie along the vessels. So when we are doing surgery for cancer, I told you minimum 12 lymph nodes have to be harvested. So these lymph nodes will be present along the vessels, and we need to make sure that we remove these lymph nodes while doing surgery. Okay. So we'll talk about colonic cancer surgery now. I'm going to just rub off the labeling so that I can tell you which surgery is done for which location. Okay. So I'm just rubbing off the labeling. It would be good revision for you to understand which vessels are being ligated, because that might be a question in the future exams as well. Okay. So now first scenario is when our cancer is present in the cecum, right? Scenario number 1 is when cancer is there in the cecum. then the surgery which we carry out is known as right hemicolectomy. So what all is done in right hemicolectomy? We remove the terminal 10 to 12 centimeters of ileum. I'm repeating again, terminal 10 to 12 centimeters of ileum are removed. Ileocecal junction, the cecum, ascending colon, hepatic flexure, and in right hemicolectomy, I just go beyond, there were two branches of the middle colic artery, the right and the left. I just go beyond the right branch of the middle colic artery. So I ligate the right branch of the middle colic artery. I ligate the right colic artery. I ligate the ileocolic artery. This much is removed in right hemicolectomy, which is done for cecal malignancies. Okay. Just to show you an image regarding this. This is right hemicolectomy for cecal malignancies. I've already told you which all structures are removed in a right hemicolectomy. Okay. Supposing the tumor is now present in the ascending colon, in the hepatic flexure, or in the transverse colon, right? In these three scenarios, we will carry out an extended right hemicolectomy. We carry out an extended right hemicolectomy. So what will be extended right? Look carefully, please. Extended right, again, terminal 10 to 12 centimeters of ileum will be removed. Ileocecal junction, I'll repeat again, terminal 10 to 12 centimeters of ileum, ileocecal junction, ascending colon, hepatic flexure, and now I am going to go beyond the left branch of the middle colic artery. Right? So now I'm ligating both right and left, so I might as well ligate the middle colic artery. So I ligate the middle colic artery, I ligate the right colic artery, and I ligate the ileocolic artery. This is extended right hemicolectomy. But I want you to observe a problem here. Now, what I've resected, now the ileum has to be anastomosed with which area? With the splenic flexure. And what did I tell you? The splenic flexure has dicey blood supply. So would I want to take a risk of anastomosing the ileum with the splenic flexure which has a dicey blood supply? No. So some surgeons, what they do is, when they do an extended right hemicolectomy, they remove the splenic flexure as well. So some surgeons, while doing an extended right hemicolectomy, I'm repeating again, some surgeons while doing an extended right hemicolectomy remove the splenic flexure as well, so that the anastomosis doesn't occur with the splenic flexure which has a dicey blood supply. I hope you understand this point. Again, let me show you the images. So this was extended right. This is also extended right which can be done. I told you here you can remove the splenic flexure as well. If the lesion is a small lesion only localized to the center of the transverse colon, a transverse colectomy can also be done, but this is extremely uncommon that you'll find such a small tumor and just end up doing a transverse colectomy. Okay. Now our patient has a tumor. Now the patient has a tumor in the splenic flexure or the descending colon, right? Splenic flexure or descending colon. If the tumor is there, then in these patients we will carry out left hemicolectomy. So what will be left hemicolectomy? Left hemicolectomy is going to be, we go beyond the left branch of the middle colic artery, and we are going to go right up till the sigmoid. And in this what we do, look, this rectum has multiple sources of blood supply, right? So we go up till the sigmoid and we do a high ligation of the inferior mesenteric artery. In left hemicolectomy, please remember this. Instead of ligating the individual branches, I will end up doing a high ligation of inferior mesenteric artery. This is what is done in left hemicolectomy. Please remember this, high ligation of inferior mesenteric artery. The blood supply of rectum does not suffer because it has multiple sources of blood supply. Okay, now if the tumor is in the sigmoid colon, if the tumor is in the sigmoid colon, then we can do a sigmoid colectomy. Then we can do a sigmoid colectomy or LAR, low anterior resection. Or we can do a low anterior resection. What exactly is low anterior resection? Let's look at this, please. So if the lesion is in the sigmoid colon, we end up doing a low anterior resection. What does low anterior resection mean? So I'm going to remove the sigmoid. I remove the sigmoid and I remove the rectum. And I remove the rectum. So this much is removed. The entire sigmoid is removed, entire rectum is removed. Why do we do this? Because of two reasons. A, because to get adequate margins, and B, also I told you that rectosigmoid is also a watershed junction. The blood supply is dicey and the anastomosis might not hold. So we remove this much. It is called low anterior because you know that the peritoneal reflection is only till the upper 1/3 of the rectum. Remember your anatomy. The peritoneal covering of the rectum is only till upper 1/3. So I open the peritoneum and go beneath the peritoneum to remove the rectum. That is why we call it low anterior resection, right? That is why we call it low anterior resection, because you're opening up the peritoneum and then going below and removing the rectum. And once we've done this, now I will anastomose the anal canal with the colon. We will do a colo-anal anastomosis. And this also I have told you, colo-anal anastomosis. You can either do a hand-sewn one, but these days what is used is a circular stapler. This circular stapler I've shown you in the sutures and knots module. I've also demonstrated it in the hemorrhoid module. A circular stapler will be used to carry out a colo-anal anastomosis, and when we do this colo-anal anastomosis, the patient is going to remain continent. That means the patient can pass stools normally. So these are the various surgeries which are carried out in patients with colonic cancers. This is low anterior resection. And I have demonstrated, I have told you which all vessels are removed. So this is very important for you to know. So this was colonic cancer. Let's move on to rectal cancer. Let's move on to rectal cancer surgery now. So again, to understand rectal cancer surgery, we need to understand a bit of the anatomy of the anorectal region. Now this is the rectum and this is the anal canal. This is the rectum, this is the anal canal. You know that this is the anal verge. The opening is the anal verge. This is the anorectal ring. The anorectal ring is formed by the levator ani muscle, right? That is what it gives the angle, the anorectal angle, because the levator ani slings around the rectum. And you also have a special line here. You know, you have the dentate line. There is a dentate line also which is present here. Now the approximate distance between the anal verge to dentate line is 2 to 2.5 centimeters. Similarly, dentate line to anorectal ring is approximately 2 to 2.5 centimeters. So the anal canal length ranges from around 4 to 5.5 centimeters. That would be the length of the anal canal. Now the importance of this is that it is in these 4 to 5 centimeters that you have your sphincters. You will have the internal anal sphincter and you have the external anal sphincter, right? So your sphincters, the internal and the external anal sphincters, out of which you know the external anal sphincter is more responsible for continence as compared to the internal anal sphincter. So both these sphincters are present in this region. So when we talk about rectal cancer surgery, you should know the principles of rectal cancer surgery. What are the principles of rectal cancer surgery? The principles are that proximal margin should be 5 centimeters. Now, proximal margin is not a problem for me. I can go up as high as I want. So, proximal margin 5 centimeters. Distal margin is an issue. This should be around 2 centimeters, the distal margin. And radial margin is also important. Radial margin should be 5 centimeters. Why is radial margin? Why do we have to take a radial margin? Because the lymph nodes are in the mesorectum. The mesorectum surrounding the rectum, the fat, that has the lymph nodes. So it is important to remove that mesorectum, because if I don't do that, I won't get enough lymph nodes. I can forget the disease there, and there can be a higher recurrence rate. Okay, so that's why radial margin is also important. So let's consider two possibilities now. Possibility number one is a patient who has a tumor, more than 5 centimeters from anal verge. More than 5 centimeters from anal verge is patient number one. And my patient number two is a patient who has a tumor within 5 centimeters from the verge. So within 5 centimeters from the verge is just at the junction of the anal canal and the rectum, whereas more than 5 centimeters is purely a rectal cancer. It's sitting in the rectum itself. Okay. Now, I've told you the principles. Let's look at the first patient and see where our resection line will go from. Proximally, I can take 5 centimeters. I have no issues. Distally, I need to take approximately 2 centimeters. So my resection line would somewhere go from here. This would be my resection line in a patient where the tumor is more than 5 centimeters. Now you can see here my resection line is going above the sphincters, right? I'm not destroying the sphincters. The sphincters are getting saved. And if the sphincters are getting saved, the patient will remain continent. Okay? So if I'm able to save the sphincters, if sphincters are being saved in tumors which are more than 5 centimeters from anal verge, then the surgery which we do is LAR, low anterior resection, which I've just explained to you, will be removal of the rectum, the sigmoid, part of the sigmoid, and then you do a coloanal anastomosis using a circular stapler. I just explained this to you. So remember, more than 5 centimeters, low anterior resection. But let's look at the other scenario now. The other scenario is this tumor which is within 5 centimeters. For this tumor, my resection line is going through here. It is going through the sphincters. I am cutting the sphincters. So when the tumor is within 5 centimeters from the anal verge, it is difficult to save the sphincters. It is difficult to save the sphincters. And patient will become incontinent. Patient will become incontinent. Therefore, the surgery which is done is known as APR, abdominoperineal resection, and permanent end colostomy. Right? So what exactly do we do? Let me just show you an image and explain to you what is done in APR. So this is APR. We know that the tumor is within 5 centimeters from the anal verge. So here what we do is we are going to remove the entire anal canal. We will remove the entire rectum. Part of the sigmoid is removed. all this is removed. The perineum is closed. Perineum is closed and a permanent end colostomy is taken out. You know colostomy, it is taken out in the abdomen and lifelong the patient is going to pass stools through that colostomy. Okay, now how exactly do we do APR? So two surgeons or two teams operate in APR. One team operates from the abdomen and one team operates from the perineum. Okay, so if you've seen an APR, you would see that one team is operating from the abdomen, one is operating from the perineum, and the patient is in a lithotomy position, a semi-lithotomy position. And we go between wind and water. That is what classically we had been taught. We go between wind and water. That means the plane of dissection is between the rectum and the bladder, right? So the team which is operating from the abdomen will start lifting up the rectum, from the sacrum. You know, rectum is adherent to the sacrum. So the team from the abdomen starts lifting the rectum from the sacrum and anteriorly of the bladder. Okay. The perineal team also comes from below, dissects the anal canal, dissects the rectum. And the final procedure or the procedure ends when the hands of the two surgeons meet inside. The one coming from below and the one going from above, when they shake hands, that means the entire rectum has been mobilized off the sacrum, and then you can deliver the specimen, close the perineal skin and create a permanent end colostomy. So this is APR. I hope you've understood the two surgeries for rectal cancers. One more point which I want you to understand here is that there was a surgeon by the name of Heald. Heald said that the lymph nodes are in the mesorectum. And he had observed that if you leave the mesorectum behind, there is a very high recurrence rate. So Heald suggested that whether LAR or APR is done, a total mesorectal excision should be done. That means remove the mesorectum so that we can remove the lymph nodes. This is known as TME, okay? Total mesorectal excision. Now there are certain updates regarding the surgery which I want you to know. There is a surgery which is known as ultra low LAR, low anterior resection, ultra low. Ultra low can be done for tumors which are approximately 4.5 centimeters, 4 to 4.5 centimeters from the anal verge as well. Some people are attempting to save the sphincters here, and usually chemoradiation, neoadjuvant chemoradiation is given. They shrink the tumor and then they attempt it. But still the standard of care remains LAR and APR, which I've already told you. This is just an update, just for your knowledge, but still stick to that 5 centimeter rule which I've explained to you. And the second update is that a type of Notes procedure is being done. This is known as TATME, transanal total mesorectal excision, transanal total mesorectal excision. TATME, this is there in Bailey as well. This is an example of a Notes procedure. I've told you what Notes is in the minimally invasive surgery module. Minimally invasive surgery is very, very important. Please watch that module if you haven't watched it till now. That Notes is a natural orifice, transluminal endoscopic surgery. So we go through a natural orifice. I'm introducing the trocar through the anal canal, right? Trocar goes through the anal canal and then I can resect the tumor. So transanal total mesorectal excision. Rather than going through the abdomen, we are doing everything through the transanal route. And this is an example of notes I've already told you. What are the indications to carry out a transanal total mesorectal excision? It can be done for T1 rectal cancers, and certain T2 cancers. So T1 and T2 are the indications to carry out transanal total mesorectal excision. This is another update, very important because this has been mentioned in Bailey as well. Okay. Let's talk about the chemo which is used in colorectal cancers now. So the chemotherapy regimes which are used in colorectal cancer, you have FOLFOX, there is FOLFIRI, there is CAPOX. These are the regimes which are used in colorectal cancers. FOLFOX has 5-fluorouracil, folinic acid, and oxyplatinum. FOLFIRI has 5-fluorouracil, folinic acid, and irinotecan. And CAPOX is capecitabine, and oxaliplatin. That is CAPOX. What are the indications for chemotherapy in colorectal cancers? The indications for chemotherapy in colorectal cancers, if the lymph node is positive, if there is T3, T4 disease, or there is metastasis, that is when chemotherapy is given in patients with colorectal cancers. So these are the chemotherapy drugs which are used, and just want to share that our patients undergo chemotherapy. I have a lot of breast cancer patients also who undergo chemotherapy, and they do experience some bit of nausea. Sometimes they have vomiting as well. And sometimes I feel as a doctor, it becomes very difficult for us to understand what a cancer patient is going through. But there have been two instances in life where, I've very closely related to what they actually go through. So one of these experiences was in South Africa when we had gone whale watching, and we were 6 of us in a small boat and choppy waters. We were trying to sight whales, and because of the choppy waters, all of us started experiencing nausea. And by the end of it, we had a great sighting. This was a picture which I clicked. We had a great sighting, but by the end of it, all of us had vomited at least 2 or 3 times. And that was the first time, I could actually understand the pain which cancer patients go through. And the second situation, a lot of cancer patients also complain of loss of taste, loss of smell because of chemotherapy drugs. And during my battle with COVID, that was the second thing which I experienced. Having no taste, how awful that feels like, was something which I experienced during COVID. So just to conclude, I want to say that we should be empathetic towards the needs of a cancer patient or any patient per se. And we should not ignore their symptoms because they actually go through a lot. Okay. So sorry for diverting from off the topic. I just wanted to share this thing with you. So that was regarding chemotherapy for colorectal cancers. Radiotherapy is only for rectal cancers. This I've told you is only for rectal cancers. Radiotherapy is there. So please remember this. There's no role of radiotherapy for colonic cancers. This has been asked in the exam multiple times. Now for rectal cancer, combined chemoradiation can also be used. And combined chemoradiation has better effect than chemo alone or RT alone. And some of these chemo drugs also act as radiosensitizers. They enhance the effect of radiotherapy. Now, this combined chemoradiation in patients can also be given in the neoadjuvant setting. Neoadjuvant, is before surgery. So it can also be given in the neoadjuvant setting. And the neoadjuvant setting, there can be 2 types of regimes which are there. You can have a short course chemo RT or short course RT, or you can have a long course treatment. Short course is when for 5 to 6 days radiotherapy is given and then we can carry out surgery. Long course is when it is for 5 to 6 weeks chemoradiation. Then we wait for 5 to 6 weeks. Then we wait for 5 to 6 weeks and then we carry out surgery. So this was radiotherapy. There's one more radiotherapy technique which has been mentioned in Bailey, that is intracavity radiotherapy. Intracavity radiotherapy for rectal cancers. This is also known as contact radiotherapy. So it is basically a type of brachytherapy. I've told you brachytherapy is when directly electrodes are implanted, and the name of this technique is the Papillon technique. So just remember the name. It is a type of a contact radiotherapy which is used in rectal cancers. Okay. Now, in addition to this, immunotherapy, I told you, immunotherapy can also be used. Immunotherapy is only used in metastatic or recurrent colorectal cancers. Metastatic or recurrent colorectal cancers. And the various agents which can be used are bevacizumab. Bevacizumab, you know, is a monoclonal antibody against VEGF, vascular endothelial growth factor. It is a monoclonal antibody against VEGF. You can use cetuximab. Cetuximab is a monoclonal antibody against EGFR, epidermal growth factor receptor. Another new agent is pantimumab. That is also against EGFR, epidermal growth factor receptor. And you also have pembrolizumab. Pembrolizumab and nivolumab. So these are against PD-L1, right? So these are PD-L1 inhibitors. And pembrolizumab and nivolumab are used in those patients who exhibit microsatellite instability. You know, microsatellite instability was seen in those patients who had Lynch syndrome, MSH and MLH, microsatellite instability. This therapy can be used in those patients. So you should know these immunotherapy agents in colorectal cancers as well. Now, another thing which I want to tell you, that liver is the most common site. The most common site for colorectal cancer metastasis is liver. Colorectal cancer is one of those cancers where metastatectomy also has a role. Metastatectomy improves survival. So that means if you can resect the liver metastasis, it will improve the survival. Now, what are the indications for resecting this liver metastasis? So the old guidelines were less than 3 mets in one lobe, you could resect it. But the new guidelines are that number of mets is not a criteria. Number of mets is not a criteria. These should be resectable, and after resection, at least 25% FLR should be there. If you've listened to the module on liver cancers, I've told you what FLR there is. FLR is functional liver reserve. So you can resect as many mets as you want to, provided they are resectable, but you should leave behind at least 25% functional liver reserve. Then only you will be able to do this surgery. So this is another thing which you should know. Metastatectomy has a role, but you should leave behind at least 25% FLR. The final point is that the most important prognostic factor for colorectal cancers, is the lymph node status. This is a better prognostic factor than the stage of the disease. So if both are there in the options, you will mark lymph node status better than the stage. So this was the management of colorectal cancers. I've told you the surgeries, they are very important. In fact, each and every point regarding colorectal cancers has been asked in the MCQ exam. Now, there is one final thing which I want to cover, and this thing is not only for colorectal cancers, it is for, in general, most of the surgeries which we do these days, we follow the ERAS protocol. We follow the ERAS protocol. The ERAS protocol, the full form has been asked in the exam. It is Enhanced Recovery After Surgery. Enhanced Recovery After Surgery Protocol. So basically, we want patients to recover faster, have less pain, and in a lot of situations like breast surgery, have daycare surgeries, or cholecystectomy, have daycare surgeries. So what are the interventions which we've made in this ERAS protocol which enable faster recovery of the patient? So ERAS protocol, the things which you need to remember, there is pre-surgical carbohydrate loading which is done. Pre-surgical carbohydrate loading which is done. Early initiation of enteral nutrition, early initiation of enteral feeds is done. As soon as the bowel sounds appear or flatus pass, early initiation of enteral feeds is done. No Ryle's tube, no drains are inserted. They also help in faster recovery. No Ryle's tube, no drains. Early mobilization is done in these patients. Early mobilization is done, and adequate painkillers are given. And adequate painkillers are given. So these are some of the ERAS protocols which are followed, which help in enhanced recovery or faster recovery of patients following any surgery, including colorectal cancer surgery. One final thing which you should know about colorectal cancer surgery, you can add to your notes, that whether you do open colorectal cancer surgery or laparoscopic colorectal cancer surgery, the oncological outcome, the cancer outcome remains the same. So lap versus open, either one can be done for colorectal cancers, provided you can get the adequate amount of lymph nodes and you can get adequate margins. Another thing which I want to tell you in the surgery of colorectal cancers, and this is a potential question for your Central Institute exams as well, is emergency presentation. With obstruction, right? So as I told you, if you remember the module on bowel obstruction, I told you cancers are the most common cause of large bowel obstruction or colonic obstruction. So these patients with colorectal cancers can present to the emergency with obstruction, and what will be the treatment modalities at that time? So you know that if there is obstruction, the investigation of choice is CECT. That will tell us that there is obstruction and that's due to a mass, and we have to manage the patient. So let's look at the scenarios and what are the various surgeries done. The reason I'm smiling is because, usually in the emergency, you have postgraduates and a senior resident who's posted there. So if this patient comes when only postgraduates are there, only residents are there, and you get a patient with obstruction, then what will be the surgery which will be performed at night? They will just do a diverting colostomy. They will just take out a diverting colostomy, right? So what does that mean? Supposing you have a patient here who has come with a sigmoid colon growth or a rectal growth here. There is a growth which is completely obstructing. So the resident will do nothing, will cut here and will just take out a proximal diverting colostomy, and that will be the end of it. They can close this end and keep it inside, and if they close this end and keep it inside, this is known as Hartmann's procedure, right? We take out a proximal colostomy and we close the end and keep it inside. This is Hartmann's procedure. But I want you to understand one thing here. This end which we've closed and kept inside, there is still a growth inside there. And because the growth is obstructing, if mucus accumulates there, then what is going to happen? That mucus will open up, it will burst through this and cause a perforation and cause more problems for us. So another option available to us, rather than a Hartmann's, we can do a Paul Mikulicz surgery. We can do a Paul Mikulicz surgery. So Paul Mikulicz surgery is going to be, this was the tumor which was obstructing, okay. Hartmann's was when we were closing one end and keeping it inside. In Paul Mikulicz, what do? We are going to cut here. I'm going to cut here. I'm going to bring out this end as the proximal end. I'm going to bring out as a colostomy. But the distal end I'm not going to close. The distal end also I will bring it outside. I'm going to bring the distal end also outside. This was my tumor. I'm going to bring out the distal end outside as a mucus fistula, so that mucus can escape out, because it cannot go down because of the constricting growth. It can at least escape out and there is no perforation. So this is Paul Mikulicz procedure. You should also know about this. Now supposing you have a senior surgeon, when the patient comes to the emergency, they can even carry out a resection or a definitive surgery. A definitive surgery can also be performed depending on the expertise of the surgeon. But nowadays another thing which is being done, if there is a gastroenterologist who is present there, they are putting stents. They put in a stent through the tumor to temporarily relieve the obstruction, and then the surgeon can go in and do the surgery. So these are the 4 situations or the 4 scenarios which can be done if a patient with colorectal cancer comes to the emergency with obstruction. You should know this. The question is going to come this way only, that residents are posted, you get a patient with obstruction, which surgery will you perform? I've already told you which surgical procedures can be done at that time. One final thing which you can add to your notes of colorectal cancer, CEA is a tumor marker for colorectal cancers. Carcinoembryonic antigen is a tumor marker for colorectal cancers, and it can be used for monitoring the disease after therapy. Now the last topic in this module is regarding anal cancers, is anal carcinoma. Now anal carcinoma can be of 2 types. Anal carcinomas are majority squamous cell carcinomas. Majority are squamous cell carcinomas. Sometimes you can have an adenocarcinoma. Sometimes it can be an adenocarcinoma. Right? Now if it is an adenocarcinoma, manage like rectal cancer. The management is the same as rectal cancer. What I'm going to talk about is squamous cell carcinoma of the anal canal. Now squamous cell carcinoma of the anal canal, the risk factors are human papilloma virus and post-transplant. This can be seen. It can be seen in immunocompromised patients. Right? So those are the risk factors for squamous cell carcinoma of the anal canal. The clinical features, the patient will present with bleeding. Patient can come with bleeding. Patient can come with a mass. Patient can come with obstruction. Those will be the clinical features. On examination, if you do a digital rectal examination, I've told you about a digital rectal examination, you can feel this growth. You can even feel this growth, and because this is below the dentate line, can be below the dentate line, inguinal lymph nodes can also be enlarged. Inguinal lymph nodes can also be enlarged. How do we make the diagnosis? The diagnosis will be made by a biopsy. And to determine the extent of the disease, we do an MRI. Now I want you to understand a problem here. Let's talk about the management of these patients. So the problem is that this tumor is in the anal canal, which I told you is the 4 to 5 centimeter region. And that is the region which has the sphincters. So if we have to operate these patients, all these patients will land up with which surgery? APR. And APR, you know, we cannot preserve the sphincters, so the patient has to live with a colostomy lifelong. Now that's a big problem, to live with a colostomy lifelong. So that is why instead of first away going and doing an APR in all these patients with anal cancers, the treatment of choice these days, and this has been asked 3 or 4 times in the exam, the treatment of choice for anal cancers initially is Nigro's regime. Nigro's regime has been asked in the exam. Nigro's regime is combined chemoradiation. Nigro's regime is combined chemoradiation. That is Nigro's regime. It is a 1 month long treatment. It is a 1 month long treatment which includes radiotherapy and chemotherapy. Chemotherapy is 5-fluorouracil plus mitomycin or cisplatin. And once this therapy is given, there can be 2 scenarios. One is that the tumor resolves completely. Tumor resolves completely. And if the tumor resolves completely, we keep on monitoring these patients. We keep on monitoring these patients because at least 20 to 30% will have a recurrence. Will have a recurrence. On the other hand, if there is residual tumor, you know that it is in the anal canal, these patients will land up with an APR surgery, abdominoperineal resection. And if there is a recurrence also, then also they land up with an abdominoperineal resection or APR, which I've already explained to you. This is the management of anal cancers, and that brings us to the end of this module. Now, before I discuss the MCQs, if you have any doubts regarding this module or any surgery question, please, you can ask me your questions on the Marrolinks Facebook group. This Facebook group has been specially made for all of you. You can just send a request, we'll accept that, and you can post your queries there and we'll answer them. Or if you have a personal query, you can just message me on any of my social media handles. The best is going to be Left-Handed Surgeon on Instagram, where I can see your query and reply to that. Let's just do a few questions. A 56-year-old presents to the emergency with large bowel obstruction and he has a constricting growth in the rectosigmoid junction. Only residents are available in the emergency OT. I just covered the scenario for you. Which surgery will you perform? So we will do a proximal colostomy with a mucus fistula. I told you the name of this surgery is Paul Mikulitz surgery. Okay. You have a 67-year-old male with a 3 into 2 centimeter cecal cancer. Cecal, you know, we will carry out right hemicolectomy. 55-year-old male with cancer in the middle rectum with no evidence of lymph node involvement. I don't want you to get confused here. They are saying middle rectum, not the anal canal, rectum. So it's more than 5 centimeters. It's more than 5 centimeters from the anal verge. And more than 5 centimeters from the anal verge, LAR, low anterior resection. 45-year-old male with anal cancer who still has residual disease after Nigro's regime. We just covered if you have residual or recurrent anal cancer, APR, abdominoperineal resection, is the surgery. You can be given a visual question like this where you can be asked what is the Duke staging. You can see that the tumor is going outside the bowel wall and there are lymph nodes. So this is a C2 disease because lymph nodes are there and it is going beyond the muscle layer. Which criteria is used to select patients for microsatellite instability testing? It is the Bethesda criteria. Amsterdam criteria is the criteria to diagnose Lynch syndrome. You have a 50-year-old man who's come with a 2-month history of weakness. He is found to have anemia. Colonoscopy reveals a fungating mass in the cecum. PET-CT reveals that there is a single lesion in the liver also which is metastatic. I have told you, even if you have metastatic lesions in the liver, you can still carry out surgery. So the treatment here would be right hemicolectomy with removal of at least 12 lymph nodes and resection of the liver lesion. So these were some MCQs for final years. What is important? You can be asked a short note on colorectal cancers. Polyps are very important, especially Peutz-Jeghers syndrome polyps. Peutz-Jeghers syndrome has been asked. FAP syndrome is asked as a short note, and you should also know the adenoma carcinoma sequence. You should also know the adenoma carcinoma sequence. So that was regarding this module. Thank you.